first of all, I'm looking for the computer to be combined with the beamer. And I take the time to say thank you to the board. Thank you to everybody staying here so long. Thank you to the previous speakers giving me some important hints. And thank you to Kaspar treating me yesterday. I'm still suffering from his treatment today.
It wasn't a sham treatment.
He calls it a healing crisis. I call it sinusitis. And, okay. Let's see what's that. Now, these are two of my children. I have four. And I'm going to show you all of my children in the second slide. I'm sorry, I have to restart the computer. Now, all right. One of the reasons why I got the new job is because I finished my thesis 2 years ago, and my new job, which I have since 4 weeks now, is the head of study in the Fresenius Hochschule of Munich. Fresenius Hochschule is a university which offers a 4 years Bachelor of Science study in osteopathy, and that study runs already since 2 years at Idstein next to Frankfurt. So Germany comes out a bit. There we are. Besides that, since I finished my master, I'm allowed to teach, so I'm teaching also at the part-time training at the Osteopathic Academy of Munich, which is a 5-year course for doctors and physiotherapists and there we go. And you can see the sign down here. Now what I like also is doing some ski touring, going sledding with my children, just resting on the fireplace in the summer, having a great time in the garden. If I have got time, I like to ride my motorcycle or play some golf. And this year I almost had a sabbatical, giving me the chance to go through Morocco with a mobile home for 2 months. It was very exciting. Right. And one of the reasons I'm here is that this is the top phase of my study, treatment of irritable bowel. And to give you an information what irritable bowel is louder, louder. I tried. To find out what is irritable bowel and to deal with the subject, I did a research in PubMed. And the medical mesh term was irritable bowel, and I found out that I got some thousands of citations which I had to deal with, so I put some limits and I focused on guidelines, which at the end of the day was some 150, but the result of the guidelines was very specific information to irritable bowel. So there is a diagnostic criteria according to a process which is called Rome process, and the latest one is the Rome 3 process or Rome 3 conference, because it was started somewhere in Rome. So what is irritable bowel? Irritable bowel is a chronic condition, and you should have abdominal pain or discomfort for more than 3 days in the last 3 months, and you also should have 2 of the following 3 features: relief with defecation, sorry, and an association with stool habits. Supporting symptoms are bloating, normal stool form or frequency, straining at defecations, urgency, which means if you feel that you have to defecate, it should be very next to the toilet. Feeling of incomplete evacuation and mucus in the feces. What is done? Usually, medical doctors give advice to nutrition. They prescribe drugs on demand. Also, they don't have any specific drug for irritable bowel, so no. So they give patients suffering from irritable bowel the same drugs as if you have symptoms without having irritable bowel. If you're motivated, you're sent to psychotherapy. Probiotics are recommended for all forms of IBS. Anybody here who does not know what probiotics are? Probiotics are something like opposite of antibiotics. So they contain living bacteria, which are supposed to help the intestines. Complementary and alternative medicine is controversial, discussed, but acupuncture and some phytotherapeutics seem to help. And next step was to look what has osteopathy to offer for irritable bowel patients. And my literature research for osteopathy was first the German Academy for Osteopathy and the Austrian Osteopathic Research website, but also Ostmed and the iGERM and the Journal of the American Osteopaths, and that's it. And I found 7 studies, but one study was only an abstract of a presentation, so that study had or has a high risk of bias. The risk of bias, is anybody familiar with risk of bias? Yes? Right. Now, all of them find out that osteopathy is helpful. All of them emphasize that more studies should be done, but none of them combined allopathy, so taking drugs, with osteopathy. In my opinion, this is a mistake, because all the patients with irritable bowel suffer from months to years, and they have their drugs already. Only the ones who have the initial diagnosis, and they get perhaps for the first time drugs. But taking a patient the drugs that helped him in the past is ethically problematic, perhaps. So I decided to investigate that, especially because American osteopaths suggest that osteopathy should be combined with allopathy, diet, and exercises. American literature for me was Kuchera and Kuchera, Osteopathic Considerations in Systemic Dysfunction, and the Foundations of Osteopathic Medicine. Right, sorry. Our research question is it useful to integrate osteopathy in a regime together with drugs? I chose within subject design, which we've heard of a lot today and yesterday. My including and excluding criteria followed the Rome 3 criteria, and I chose only middle severity of symptoms. Mild severity of symptoms means that it gets problematically to show changes, and severe forms of IBS should be treated in special centers. So, I recruited 20 subjects, 11 female, 9 male, average age. 53 years. This should be a representative sample because women usually suffer more often in IBS, of IBS, in IBS. What do you say? In? Up? In?
From.
Right. And I found the best way of recruiting patients was advertising in weekly newspapers. I'm sure you have that also in the UK. Every household gets one, and it was the best way of recruiting because talking to gastroenterologists was often, yeah, do it, super, fine, but they didn't refer anybody. One patient came to me, but she wasn't eligible for the study because she didn't suffer from anything. Good. At 5 days, data was collected in a diary. We're going to have a look at the diary now. I'm going to explain a bit. His functional complaints are those who are which are in the Rome 3 criteria. So it is bloating, it is pain, and it is change in bowel habits, and so on. I asked especially for pain, frequency of pain and severity of pain. I asked for the overall well-being, and I asked, do you take a diet? I wanted also the patients to
you want the laser pointer?
too nervous.
It's on the table. And you need to put the...
Good. To documentate the intake of drugs, but that was a mistake to do it like that because I asked you're going to see it on the next slide, every 2 weeks, and they should report each time they came to me the intake of drugs, looking past for the last 2 weeks. And if anybody would like to documentate the intake of drugs, you must do it daily. So this didn't work. And I also looked at their quality of life. I used the GIQLI, Gastrointestinal Quality of Life Index questionnaire. And my independent variables were osteopathic treatment in a 4-week time window according to a black box design. So black box means that also I didn't say how often or when I wanted to see the patients. I let it open to me. And this is, in my opinion, a better way than just predefining every second week I want to see you, because sometimes I don't have the feeling that I want to wait 2 weeks, or sometimes I have the feeling I want to see you in 3 or 4 weeks again. Right. So, timetable. T0 was the onset of study, where I gathered a baseline, and then I waited 2 weeks. And that was taking the first real measurement. In the run-in phase, patients could once again change their drug consumption, prescribed drugs, or if I had a change in between T0 and T1 in the sufferings, in the showings, but how many pain they have or stuff like that, I would have a problem, because I couldn't be sure that if they self-monitor, if they change. Right. So I had that osteopathic time window, 4 weeks, and I had a follow-up 6 weeks after the last osteopathic treatment. results. As we see in between T0 and T1, and we see that in any slide, symptoms didn't change. But as soon as I started with treatment, symptoms improved and well-being increased. So, the intensity and the frequency of abdominal pain decreased, statistically highly significant, which means in Germany it usually is statistically significant if you have a P lower than 0.05. Highly significant is 0.01. And if you look at the P here and there, it's not too bad. The total of functional complaints also decreased, statistically highly significant at T3 and T4. So T3, once again, is the end of osteopathic treatment, and T4 is the follow-up. The well-being also was better. And single complaints also improved: diarrhea, straining, mucus, and bloating, but some not. Some only improved at T3. Constipation, feeling of incomplete evacuation, urgency, and quality of life also. So for me, it is doubtful at that point already if 4 weeks are enough. Discussion. The approach to combine osteopathy with allopathy was justified. This is very common in the US and compatible with the reality in Europe. That's what I said before. The reality is patients come taking drugs. The results of this study correspond to the results of other published studies. One more sentence to that. Method of black box seems to be more efficient than just referring to selected regions. Now I had some studies which predefined the treatment to several regions of the body, and within my trial, patients seemed to react earlier. And one group who predefined 4 places of the body to treat, they said they wouldn't do it again. They would use the black box for further studies. Osteopathic considerations concerning treatment of Couchera seem to be correct. I broke them down. Normalize automatic activity to the intestine, promote good lymphatic flow, and normalize joint somatic dysfunction, especially in the areas of sympathetic innervation of the GI tract. Now this is somewhere in between T5 and T12. And I can say they seem to be correct because I also had documented all my findings, my osteopathic findings, and in the way they improved, symptoms diminished. Now, this sentence is out of a guideline. In others, there seem to be spinal facilitations present in the thoracic spine and the sacrum. This is not osteopathic literature, it is medical literature. And this is also very interesting for us because it is the spinal facilitations we all know. Right. Osteopathy operates long-lasting. Now, this means if you take a drug and you stop taking the drug, you should normally symptoms come back very soon. But in osteopathy, as we saw in my results and also in the other results in the other studies, was that it lasted over the day that osteopathy was performed. limitations of my study. If I would do it again, I would compare osteopathy and allopathy to osteopathy alone. This is what former researchers have done. Only now they've forbidden patients to take drugs, and this would be a better approach to the topic. And there is a validated questionnaire which is called IBS-QOL, quality of life for IBS, which should be taken. The GI-QLI is much broader, and in terms of IBS too broad, because there are specific questions to bowel habits which are not in the IBS-QOL. In my opinion, it should be done, the investigation of osteopathy, this CAM, probiotics or psychotherapy. And of course, more research is needed. Now, what has it done, that study, with me? I was very happy when I pressed the send to button in Outlook.
What's it like?
You should know it.
I look forward to it.
It changed my view concerning evidence-based medicine, because as we've seen in the box plots, they are very big. So that means that not anybody responded very well. And as we see here, we have got some, what do we call it? Outliers. Outliers. And my personal opinion was, like every time in my practice, but sometimes it works, sometimes not. Sometimes it takes a while. And we as osteopaths do not treat statistics, we treat patients. And this is the whole, or a big criticism of me, if osteopathy is, well, in hunting EBM.
Evidence-based medicine.
Yeah.
Sorry, say the sentence again. The big question for you is?
It's chasing after. So your doubt whether osteopathy is really good enough situated in chasing the evidence-based medicine.
Chasing what? Okay. Now that's it.
From your audience.
I can, I guess I'm a little stupid and wrong, so but what's your hypothesis? Did you have any slides on your book? What's the same hypothesis? What do you want to show?
My research question,
Yeah.
is it useful to integrate osteopathy in a regime of, together with drugs?
Okay, sorry, I didn't see that.
Right. And the answer is yes.
And yet, in your lesson, you say that at your conclusion, you said you wouldn't do the study again with drugs.
I would, but I would compare it. I wouldn't change a within subject design. I would compare osteopathy and drugs with osteopathy alone.
Okay.
But are you going to find many people who aren't on some of the drugs there?
That's a big problem.
With a certain level of severity, I suppose, you have to, your inclusion criteria must be a certain level of severity.
The severity of symptoms was middle.
Right.
Middle severity. But that's not according to drugs, is it?
No, well, sometimes people will meet, beyond drugs. If they've got a light level of symptoms, they might not be on drugs.
Yes, but if you have a mild level, it could be hard to measure differences.
Yeah.
So how do you measure improvement if you have only mild symptoms?
I
I guess you get people who don't want to take drugs, so if they were going into a trial where there was a possibility of not taking any medication, then
There'll be
Perhaps
some
it works,
selecting,
but-
so there may well be
but
some
they still have to be
people
known
or
as reality.
we get the placebo differences again, don't we? They won't be the same group.
Can I ask why you chose a 4-week time frame?
I compared it with studies which have been done before, and some of them chose 4 weeks and showed good results. So, with that.
Is that enough?
Yes, I have a question to the error bars and box plots. How is it? How is it possible that the box plot shows such an unequal distribution, but the 59 confidence interval not? Did the statistical made a test for normal contribution distribution?
She did, but as you can see of the box plots, this can be normal.
Yes, but
And
the
sometimes
error
the
bars,
whiskers. You mean the whiskers?
no, I mean the error bars left on the box plot.
Here, the confidence
That's,
interval.
bitte? This is the error bar with a 95% confidence interval.
Yeah.
If you have such an unequal distribution, the error bars, the 95 confidence interval cannot be so equal.
Okay.
I don't get the conclusion between these two charts.
I don't either because I'm not familiar
It's
with
strange.
statistical.
So somebody else did the statistics for you.
Yes.
Yeah, that's always a problem. I mean,
Yes.
it's just,
Yes.
you can't really.
Now, to be honest, I studied economics before I went to healthcare, and I had 2 statistic examines. I did it quite well, but talking to a statistic, I didn't understand a word.
I think it's better to took only the box plot.
Yeah,
To-
so you
to
take
see
care of the
our
box
box
plots and not the
plot.
confidence interval.
That would be nice. Anybody else? Okay.
So other than just changing your comparison group, is there anything else that you would do differently if you were going to do it again?
Well, as I said, the documentation of the intake of drugs should be better. The IBS QL should be taken because they are more precise for IBS, not to draw. Well, recruitment was quite well because other studies recruited from a clinical area surrounding, and I recruited directly from the street, from their homes, and a lot of patients with IBS don't go to doctors. They know they have it, and if you recruit only in a clinical surrounding, the study is biased.
Do you think you've got better at treating it since you've done the study? Do you think your treatment effectiveness has improved since you finished the study? In what you've learned, has it helped you to be more effective?
In terms of IBS or in
In
terms
terms of
also-
IBS?
Yes. Yes, of course. It would be a shame if it.
So how have you improved?
Let me answer that in my practice.
Right.
Okay. Let's move on to
Yeah.
Well done, Frank.
Always been interested in is answering the questions, how do I know where to start? And when Stuart Croft was at Munich some couple hundreds of years ago. Thank you. It was in the early 14th century, I think. I asked Stuart, how do you know where to start? And he said, well, after all the analysis and examination, and it's still, and I can't remember what he was always, or things he said, but it is interesting to think about it. So, I want to talk to you about testings. No, wrong sheet. If you've done your examination and you've got all the findings and you've done all your considerations, as we heard yesterday at the practical of Ute, she tends to do it intuitively. Sorry. Intuitively. Right. But I think she could test it and be more sure. So instead of doing it intuitively, she could do it reflectively. I'm far away of criticizing anybody inside here, but this is my way. This is my history. I tend to do it reflectively. Where to start? So, what are conditions of testing? I should be able to answer a few questions according to my own level of training, according to the question, is osteopathy the right therapy for this person right now? Or do we need somebody or something else? Does the patient want to be asked? I come up to it later because I take the response of the tissues to answer that question. Do we need another fulcrum for the health? Perhaps another person in the room, or another person to be appreciated? And is it the right time and the right place to treat? Right. We're all familiar with testings, parameters like range of motion, strength and tone, tension, stroke, temperature, PRM, and it doesn't depend on which parameter you focus on. You're always looking for a change of the parameter when you touch the patient anywhere to get an answer. So this is what we're going to do later on. Now, how I'm going to do it. Is anybody here familiar with the term of general listening and local listening? Right. Anybody knows the model of the spheres? So we're going to start with that. Yeah. And with the practice of inhibition. Do you know inhibition? Right. What I always find interesting...
Frank, those are all things which could be understood in a general way, but I don't know what you mean by them at all.
Right, we're going to see that when we're doing...
Yeah, I wouldn't like you to think that I understand all this as you...
When I show it, it comes more clear, but I want to set up right here. What is important is, what are you asking the tissues for? Is it, where are you suffering? Or where do you want me to start with the treatment? And it could be a completely different answer. What are usual answers of tissues? Relaxing or straining, PRM is getting stronger or weaker. And if you get no answer, then you have perhaps ask the wrong question, or the question is not precise enough, or your inner heel is too tired, or your patient is not in balance, or you're not in balance.